Good morning. Welcome to this morning's residential lecture that will be held by Ada Adstasht. She is just starting her third year of residency at our department and will tackle the topic of hiatal hernia.
Thank you very much. Good morning, everyone, and I would like to welcome you to our today's presentation on hiatal hernia. I will dive straight into the topic and would like to tell you something of the sites of the hernia. This hernia occurs via or through the diaphragm, and we have a lot of sites where hernias can occur, as you can see here. But actually, the hiatal hernia is at none of these sites. It is actually here. It is through the esophageal hiatus. So the definition of a hiatal hernia is a protrusion, a herniation of an abdominal structure into the thoracic cavity, and this through the esophageal hiatus. We have different types of hiatal hernia, starting with type 1. This is a sliding hernia, which is most common, and where the gastroesophageal junction and the cardia slide up into the thoracic cavity. This can be intermittent, whereas the fundus remains below the diaphragm. In contrast to that, we have the paraesophageal hernia, where it is actually vice versa. So the gastroesophageal junction remains under the diaphragm, but part of the fundus herniates into the thoracic cavity. Then we have type 3. This is a mixed hernia, and as the name actually gives it away, we have a mixture of type 1 and type 2. So the gastroesophageal junction here and part of the fundus prolapses through the hiatus. And type 4, the complex hiatal hernias, which is actually a rare condition, but in this case, we have a herniation of any abdominal structure other than the stomach. So this can be the omentum, it can be the colon, it can be the spleen even. And then there is one type, the paraesophageal type 2, which has an extreme type. Maybe one of my colleagues knows how it is called?
I guess it's the upside down stomach.
Exactly, thank you. It is the upside down stomach. So here in this case, the entire stomach actually herniates into the thoracic cavity. And the problem here is, which can cause an emergency, is that it rotates on its own axis and can cause a total obstruction. And this is actually connected with high mortality and a high morbidity rate due to the strangulation of the stomach. So a hiatal hernia is actually given in 50% of the population older than 50 years. More females have that in comparison to male patients and the Western population, which is why we have an assumption that it is connected to lifestyle and eating habits. And it is more common on the left-handed side than on the right-handed side, as the liver can protect the diaphragm. Okay, so let's talk about the risk factors. Do you know maybe one or two risk factors?
Age would be one.
Exactly. So age is a risk factor for developing a hiatal hernia. And this is because we have a phrenoesophageal ligament that actually stabilizes the cardia. And with advanced age, it can lead to weakening of this phrenoesophageal ligament and causes less stability of the cardia and also less movement or less independent movement of the esophagus and the diaphragm while eating and breathing. Another risk factor is smoking, and here it is due to the fact that smoking causes a loss of elastin fibers in the diaphragm crura. And the last one I would like to tell you is increased intra-abdominal pressure. This can be due to obesity or pregnancy or even chronic obstipation. Let's talk about the symptoms. In type 1, if you recapitulate, the gastroesophageal junction is above the diaphragm. So here mostly it is asymptomatic, but if the patients are symptomatic, they have reflux, they suffer from reflux and can have gastrointestinal bleeding due to ulcerations that can occur in the esophagus. Reflux and hiatal hernias are associated with each other. This is due to the fact that we have a wearing out of the phrenoesophageal ligament due to, for example, frequent swallowing in patients who have reflux. And then when the ligament is weakened, the stability of the cardia is not given anymore, And that's why it can cause a protrusion of the cardia into the thoracic cavity. And when we have this protrusion of the cardia, this leads to a weakening of the lower esophageal sphincter that again, due to the dislocation, that again can cause reflux. So these two reflux and hiatal hernia are associated with each other. 80% of all patients with reflux have a hiatal hernia, and vice versa, 60% of all patients with hiatal hernia suffer from a gastroesophageal reflux disease. But which one is first, we don't know. In comparison to type 1, in type 2 to type 4 hiatal hernias, patients actually suffer from obstructive symptoms like dysphagia and regurgitation, and this can even lead to breathing problems such as asthma. In type 3 and type 4, we can also have a reflux symptomatic. So what do we do for a diagnostic workup? First of all, of course, we have to go for the anamnesis. We ask the patient for typical symptoms for type 1. So does he or she suffer from heartburn or reflux or regurgitation? And another very important question is actually, do they take PPIs and do they help? And if these questions are answered with yes, no further diagnostics is needed. But if the answer is no, we should go for endoscopy. Another question is whether the patient suffers from atypical symptoms, such as difficulty breathing that leads to asthma or persisting cough or bad breath or chest pain. Or do we have a suspicion for a type 2 to type 4 hernia? Do we have any obstructional symptoms such as dysphagia? If these questions are answered with yes, we also go for endoscopy. But why do we do an upper endoscopy? First of all, we would like to objectify an esophagitis, which is classified by the Los Angeles classification. And this goes from grade A with small erosions to grade D, where we find an extended erosion that are confluent, extending over more than 75% of the circumference. We also have to rule out Barrett esophagus or malignancy as the reflux and that can cause metaplasia in a Barrett esophagus is a pre-malignant. So what happens actually is that the acid damages the mucosa, and the squamous epithelium that is in the esophagus is replaced by non-ciliated columnar epithelium, and this is the intestinal metaplasia that is the pre-malignant. And the physiological transformation zone between the squamous and the columnar epithelium is shifted upwards. And as a classification for the Barrett mucosa, we have the Prague classification that looks at the extension of up to the circumference, starting from the proximal cardia folds to the circumference, and then the longest tongue of the Barrett esophagus. And in order to see whether we have a higher prevalence of a hiatal hernia, we also do an endoscopy with an inversion of the endoscope. So we can take a look at the mucosal fold that is built by the gastroesophageal valve. Grade 1 and 2 are actually interpreted as physiological. So here you can see that around the endoscope, we have a prominent fold. And in grade 1, it is actually sitting tight around the endoscope. Whereas in grade 2, we can find periods of rapid opening and closing around the endoscope. Whereas higher Hill grades are associated with hiatal hernias. So this is actually an indirect sign of a hiatal hernia. As another diagnostic workup, we can do a high resolution manometry. And the questions that need to be answered here are, do we have a motility disorder in the esophagus? Is the lower esophageal sphincter weakened? Or do we find any transient relaxations of the lower esophageal sphincter? Another diagnostic workup is the impedance pH monitoring. This is actually really interesting. We have a very small, maybe 1 or 2 millimeter thick nasogastric tube that is inserted, and the patient has this for 24 hours and has a small device And whenever he feels symptoms, whenever he's symptomatic, he can press that button, and this is recorded. And this impedance pH monitoring can detect whether in this situation the patient has acid reflux or is it just a volume reflux. So he can have volume reflux and be symptomatic without it being of any acidity. So it detects the reflux episodes that are associated with the symptoms. We also do a gastrographene swallow, and here we can take a look whether the gastroesophageal junction is above or below the diaphragm. Do we have any paraesophageal hernias? Or do we find any dysmotility, or do we have a good passage of the contrast media? We can also go for a CT scan, where we find an upside down stomach or a type 4 hernia. And now about the therapy. If we have the type 1 and the patient is asymptomatic, we don't need any therapy. If the patient suffers from reflux, we can do a PPI trial with actually very good response. We can also recommend lifestyle changes, so weight loss is very important. We can recommend the patient to eat smaller portions. And if he has the symptoms at nighttime, we can recommend him to sleep in an elevated position. And maybe to prevent fatty foods or alcohol, as this can cause a lower tonus of the lower esophageal sphincter. In type 2 to 4 hiatal hernias, we also go for PPI. Actually, the indication for surgery is given here in symptomatic patients because they can have a progress in size and also a risk for incarceration. But I have to say the risk of incarceration is below 2%, so actually it is justifiable to just go for watchful therapy. Because when you take a look at, for example, the type 4, the complex hernias, you can imagine that the perioperative risk or the postoperative risks are quite high. The patient can develop pneumonia, myastenitis, so you have to weigh up carefully the chances versus the risks. Of course, when the patient has severe pain, a perforation or a total obstruction, we go straight for emergency. So whether to do PPI or surgery, for example, in symptomatic patients of type 1, there was a known LOTUS trial. It is a randomized controlled trial that compared the two groups, one group who was administered with PPI and the other group that received a laparoscopic anti-reflux surgery. And actually both groups showed very good results with high remission rates in the 5-year follow-up. So these both therapy strategies are actually comparable. So when do we do surgery for symptomatic type 1 patients? It is actually when you have a PPI non-responder, for example, in a non-erosive reflux disease, or if the patient suffers from his volume reflux, or if the patient actually had an improvement but now has a progress of his gastroesophageal reflux under the PPI, or if the patient is young and is not compliant for a lifelong PPI medication. So what are the steps of the surgical therapy? First of all, we have to do a reposition. And if needed, if the esophagus is too short, we do the colusplasty to elongate the esophagus. Then we do a dissection of the hernia sac to prevent any recurrence. We do the hiatoplasty with or without mesh, and an anti-reflux surgery in case of reflux, of course, and no esophageal motility dysfunction. Whereas in patients who have dysphagia, no reflux, and if they're rather older patients, we do a fundophrenicolpexy. And for the hiatoplasty, we use non-resorbable suture material. And here you have to be very careful not to suture it too tightly because it can subsequently cause dysphagia postoperatively. Indications for mesh augmentation, we use resorbable mesh. Is a recurrent hernia, or if we have a large hiatal defect, this is around more than 5 centimeters, or if we have a weak muscular structure of the crura, or also in type 2 paraesophageal hernias. Here in this meta-analysis from 2016, it was shown that we have a very high, or compared to mesh reinforced repair, we have a higher recurrence rate of primary suture repair, and the numbers are here 24 versus 6%. But actually, it is still very controversial to use the mesh augmentation as a standard of care, because the guidelines actually do not recommend it, or do not recommend the usage of synthetic mesh as a standard, because it can lead to stenosis or dysphagia. The mesh can cause infections, and also within the period of 5 to 10 years, it can cause erosions of the esophagus as well. So it is really actually up to the choice of the surgeon if he prefers to do it or not. There are actually different types of the mesh augmentation, just here for you to throw a glimpse at it. And then we also do the anti-reflux surgery. The aim here is to reconstruct the barrier at the level of the lower esophageal sphincter, because we said that we have a weakening there. We can do a magnetic sphincter augmentation with links, and we can also do a fundoplication. The magnetic sphincter augmentation is a magnetic device that is put around the lower esophagus, below the diaphragm, that enables the lower esophageal sphincter to be tight and to prevent reflux from the stomach. But if the patient wants to swallow anything, water or food, of course, it has to expand, and it expands just as much as it is needed for the bolus to pass into the stomach. And on the right-handed side, you see that after 1 year, it actually has very good results. We have at least 85% remission of reflux symptoms, regurgitation, heartburn. We also do a fundoplication. Here, mostly we do a Nissen fundoplication. This is a 360-degree fundoplication. We go from posterior, and here the cardia of the stomach is put around the esophagus to tighten it more. So a positive aspect here is that we have a higher pressure of the lower esophageal sphincter and a lower acid exposition. On the other hand, we have a higher incidence of dysphagia. Why? There's also the possibility to do a Toupet fundoplication. It is only 270 degrees. So here we have a lower incidence of dysphagia compared to Nissen in the first years. But the problem is that we have a persisting reflux, or it can lead to persisting reflux. And you can imagine that the patients, they come with this symptom and they really suffer from that. So actually the guidelines prefer the Nissen fundoplication due to better long-term effects and patient satisfaction. So here at our clinic, after the complete diagnostic workup in type 1 hernias with GERD, we go for hiatoplasty. We don't need any mesh, but we do an anti-reflux procedure. This can be either Nissen, Toupet, or the links. And for type 2 to 4 hernias, for bigger hernias, we go for patients under 70, also with hiatoplasty. We do a mesh augmentation with resorbable meshes, and also do an anti-reflux procedure. And if needed, we do the cholisplasty to elongate the shortened esophagus. And for patients who are older than 70 years, we do not do an anti-reflux surgery, but we go for fundophrenicopaxy. So as take-home messages, I would like you to know that especially type 1 hiatal hernias are associated with GERD. Of course, the correct diagnostic workup is crucial for a correct treatment. And surgery indications are for patients with type 1 hernias who are symptomatic and who actually have an improvement with PPIs but do not want to take it lifelong. So this can be an alternative to that. It is generally given for all symptomatic patients with type 2 to type 4 hernias. But again, remember, we have to carefully weigh up the risk versus the benefit, and in emergency situations. The surgery consists of the reposition of the hernia, dissection of the hernia sac to reduce the recurrence rate. We do hiatoplasty with or without mesh, anti-reflux surgery. And for patients more or older than 70 years, we go for a phenylkopexy. Thank you very much for your attention.
Thank you, Adak, for this very nice overview about a very common disease that most of us have to deal with patients. This is also an example here where one pill, the PPI, has basically compete with surgery and change many things and has a novelty. This is no longer a novelty. It was in the 80s. We exaggerate at the beginning, thinking there is no role for surgery. These patients are not even referred to the surgeon, but treated with PPI, with then problems in the future here in the reference. So my first question maybe you should go to Dr. Vetter or Professor Guccio here, is these patients are seen mostly today by gastroenterologists. Are they really properly referred to the surgeon? Are these cases discussed in multidisciplinary team? Because my impression, what we see here is that many of these patients, unfortunately, are not do not benefit from surgery. So that would be one of the questions. My second question is also, again, from the endoscopy. There is some endoscopic treatment that are proposed. We've seen these rings. I think that's placed by the surgeon laparoscopically. But there are also some treatment proposed by gastroenterologists. Is there serious data on that? Is that something to consider, or should we advise the patient not to go for endoscopic treatment, but to go for surgery when it is indicated? And my last question, I think today, very few, or we should probably not do this procedure in an open way, but laparoscopy or robotic. Is there any advantage of robotic surgery over laparoscopy here?
Thank you very much for your questions. In my opinion, surgeons and gastroenterologists have a different philosophy about treating this disease. From a surgeon's point of view, we have a mechanical problem of an incompetent lower esophageal sphincter that allows for reflux from gastric contents into the esophagus and causing symptoms. This is also mirrored that by the relatively low success rate of consequent PPI therapy. We have at least 30% of dropouts in conservative therapy. And in my opinion, far too few patients are referred to the surgeon. The problem is also that surgery has gained a bad reputation in some doctors, because also problems can arise after surgery, like dysphagia, you mentioned that, and complications related to mesh use. The problem is that this type of surgery is performed by many surgeons that they think it's an easy fix to perform, which in my opinion is absolutely the contrary. It's a very complex situation. You have a lot of different types of hernia. You need a lot of expertise to really perform this in an appropriate way. And it's also advisable to have an interdisciplinary board discussing those cases. We have introduced this year now also an interdisciplinary outpatient clinic with our gastroenterologists to really discuss the difficult cases. Relating to your question about the surgical access, of course, laparotomy or thoracotomy, this is the past. There's no for standard surgery, there's no place for open access surgery anymore. Most surgeons use laparoscopic procedures. Only a few have started with robotic cases. We have done this also in a few cases. We have started robotic anti-reflux surgery. We could not really, at the moment at least, see a relevant advantage of robotics in this type of surgery. But I think this is still a matter to be investigated. It's too early to really draw conclusions, and we have to wait until good data are available from the literature.
And I think there was the third question was about the endoscopic techniques by the gastroenterologists to improve the reflux. There are multiple techniques to do that, like endostitch and everything, but so far none of them have really been able to show a long-lasting effect. So there's to date, there's nothing that we can really recommend patients as an alternative to either PPI or surgery.
And if there's a hernia, there's no way to fix it by an endoscope. You can't fix a hernia. You just can augment the sphincter, but to really treat a hiatal hernia, it's quite difficult by endoscopy.
Thank you very much for this very nice overview. I have a question to Diana. How do you decide if you either go for a LINX or for an application by either Nissen or Toupet? Because I think the LINX, it seems very elegant. It's flexible, so whenever you swallow, it opens. And the Nissen or the Toupet, it's not with a foreign material, but they seem to me a little bit old-fashioned.
A very good question. So there's no really randomized controlled trials yet that really compare LINX to fundoplication, but it seems that the LINX really has a very good effect and also long-lasting effect. So it's also a bit patient preference because not every patient likes to have foreign material, and the LINX is still a foreign material. It will last forever, relatively, and it's the newer method that still needs to sort of prove itself. It's been out there for quite a while, and it initially also had issues with erosion, which was probably due to a too tight placement of the LINX, which is now sort of done more loosely. And so I think it's more personal preference. We tend to do in younger patients that are open to foreign material. We tend to do LINX now because we have good results and they're long lasting.
Maybe when I see just a slide with these rings here that Professor Guccio brought to us and was very excited a few years ago. Clearly the indication is quality of life here. Maybe you're preventing cancer or other problems, but also cost. And I would like to know what's the cost of this ring, if it's cheap or not. And I think today, every time we come with any kind of device, we must a little bit comment, since this is a common procedure, maybe many used. What's the cost of these rings?
It's about 5,000 francs, but it's completely reimbursed by the insurance. There's a GEG for that, so it's cost neutral for the hospital.
And it's easy to place, I guess, if we compare to the, it's always the same thing. We've seen that in bariatric surgery and many other, what easy can be done by everybody. So it could be also an indication that might be sometimes questionable with this. I guess we place that laparoscopically with a little bit mobilization and nothing else, huh?
Well, you need to mobilize the vagus, and you leave out the vagus. That's maybe one difficulty.
And Adak, maybe just to mention that the major interest in this country about this disease, since Rudolf Nissen, who was one of the pioneers in this disease and do the surgeries today, still I recall his name, was a chairman some years ago in the 70s in Basel. And one of his students, Dr. Rossetti, was also involved with that, and there is also a technique modified by Rossetti.
I have a question to the same system. Thank you very much. Very nice presentation. The LINX system. Precisely the same system was used as a magnetic anal sphincter for the treatment of fecal incontinence. However, it was taken from the market due to erosions of the anal canal, which have occurred in a certain number of patients. And of course, that has killed the indication for this. Has this not led to any problems? Because of course you see the same complications, but was there never a problem with the licensure of this system or insurance companies not willing to pay for that indication?
So in our personal experience for 15 years now with the LINX procedure, we did not see any erosions. I know from the registries and international data collections, the rate of erosions is in the per mil region, so a lot lower than in the with the Phoenix system for incontinence. It looks easy to implant, but you have really to know your stuff, because the details makes a difference. Just relating to your question, Professor Clavian, because the main problem we see after LINX insertion is dysphagia. Which typically lasts for about 6 months, and you have to follow those patients closely. Sometimes you even have to dilate. However, our dysphagia rate is now a lot lower than 10 years ago because we have done some modifications. We use a larger implant. We have during operation you measure the circumference of the esophagus and you choose the appropriate implant. You have different sizes at hand, and you can choose the appropriate implant. And now we choose a slightly larger implant compared to years ago, and we see less dysphagia. In the beginning of when this type of implant was introduced, there was enthusiasm, everything's fine. And then there was a little bit, the hype cycle went down because we also saw dysphagia and the downsides. And now with larger experience and knowing a bit the tricks and tips, we are getting better results and patients are quite happy, and also the surgeons, of course.
We were enthusiastic ourselves. We've implanted one system and 3 months later it was taken off the market. So,
but this is one of the very, very few implants for gastroesophageal reflux that stood the test of time. Okay, there have been about 50, 60 different implants, endoscopic, external, angel cheek prostheses, etc. They all disappeared because of complications. This is the only implant that stays here for more than a decade and still is on the market.
Okay, thank you.